Welcome, everybody, and thank you for joining us this evening. We will be presenting on Ask the Experts, what you should know about vaccinations for people with rheumatic illness. I'm Adina Batterman. I'm the Senior Manager for Inflammatory Arthritis Support and Education Programs. I'm joined this evening by Joan Westridge, who is a Social Work Coordinator for the Early Arthritis Initiative, and our distinguished guests who will be sharing their expertise on this topic. Dr. Andy Miller, who is an Associate Attending Physician and Chief of Infectious Diseases at Hospital for Special Surgery. He's also an Associate Professor of Clinical Medicine at Weill Cornell Medical College with special expertise and interest in infections in patients with rheumatic conditions. We also have our distinguished colleague and speaker, Dr. Arthur Yee, who is an assistant attending physician and rheumatologist here at Hospital for Special Surgery, as well as an assistant professor of medicine at Weill Cornell Medical College. Welcome to you both, and thank you so much for sharing your time and expertise this evening. We're going to ask you a number of questions, which our participants have shared with us and are interested in knowing about. This is a very timely discussion. We know that a lot of new vaccines have been released just recently, and it can become a daunting process to understand how to coordinate them, what to understand about them, and how to proceed and make informed decisions. So we're really glad that you'll be able to share some information so that people can make informed decisions with their physicians. Let's start off with COVID, which is especially timely considering an uptick in COVID infections and the release of a new COVID vaccine. The first question that we have is, are vaccines for COVID safe and effective for people with rheumatoid arthritis or inflammatory arthritis?
Well, I'll start with first of all, just saying that I'm grateful to be invited, and it's a pleasure to be here again. And I'm happy to answer questions as far as I see it. And you may notice that Dr. Yee and I sometimes don't quite agree on things. We don't know what we don't agree on yet, but that's simply because there's a lot that's not known about some of these topics. I'll hit that first question. First, I think that COVID vaccines are incredibly safe, and that the rates of complications, other than some arm soreness or some malaise, really feeling rotten maybe for 24 hours, beyond that, the safety is incredible. It's extremely safe. And it looks like this new vaccine that's coming out now will be effective against the COVID strains that are out in the community now. So I think that it's going to be quite effective at preventing COVID. We can talk more about what that means in 2023 compared to what that meant in 2020, because the risk of dying from COVID is much lower now for many people. But still, it's a nasty illness. You can spread it to your family. And some people are getting hospitalized and getting sick. So I think it's likely to be safe, likely to be effective, and also likely to be worth it for you to get the vaccine.
So thank you for asking me back. Andy and I go a long way, and we generally agree on things, and I do agree with what Andy has said already. I am generally an advocate for the vaccination of my patients with rheumatic illnesses. There are certain rheumatic illnesses which you could predict might be harmed by the mRNA platform. And so that we can get into that a little bit, but rheumatoid arthritis would not be one of the ones that I think would be the ones that fall into this category. I think that from a personal health and a public health hazard, from a personal and public health vantage, I think we should all try to be vaccinated. I think it's safe.
So you're pretty much in agreement on that.
Yes.
We have another question. Would you please explain the difference between the bivalent and the monovalent vaccine?
Sure. there are different, just like cats or dogs have different strains. So the cat can either be a tabby cat or a Siamese, etc. Viruses can have different strains as well. Some vaccines only hit one strain and they miss the other ones. And so a bivalent vaccine is one that hits that hits two of those strains. A bivalent vaccine often doesn't hit all of the strains available, but they'll try to aim for the main two. When you get a flu shot these days, and we'll get to the flu vaccine in a moment, that actually is a quadrivalent vaccine. There are 4 different strains that it's targeting. And so different vaccine makers have to design their vaccines different ways. Right now, the decision for this year's COVID shot is to no longer give the bivalent vaccine, but to give a single or univalent, I think the word is monovalent vaccine against COVID.
So this is I think a reflection of the concept that we're seeing an evolution, right? So epidemic evolves over time. What we saw initially is not what we see now in so many different ways, and the prominent strains now have evolved essentially since that time. I don't know what the replication time of a virus is in here, maybe an hour. But you think how many generations of viral particles have evolved in the past 3 years, and you can see what in generation time how long a human evolution that would take. So this will continue to evolve. When you hear about Andy talked about the flu, but if you talk about pneumococcus pneumonia vaccine, that's like 20 strains, right? In a sense. So you're really this is not a novel concept, but it will evolve.
Thank you. One person is asking, why so many COVID vaccines? What are the long-term effects of having so many of these vaccines?
Well, I think that I'll jump in here. It's exactly what I said. There are many vaccines because it's the viruses are constantly changing. And so what worked previously will no longer work. And so it's actually just one vaccine at any given time is what it comes down to.
Yeah, there's one example of a vaccine that changes every year. So every time you get that vaccine, it's a different vaccine. And I'll bet, I don't know about the person asking the question, but I'll bet that most people on this call are getting that vaccine that's different every year. That's the flu shot. And so far, the flu shot is one of the safest vaccines ever designed and seems to cause no long-term side effects and saves hundreds of thousands or millions of lives a year. So it does sound like a lot of vaccines, and there's been nothing but controversy and politics and too many articles, way too much press about these vaccines. But what they're doing is changing small bits of it. The platform itself, the product itself is the same, but just the RNA that's given is a little bit different, just to tune it to the virus that's out at the present time. And right now, it looks like the COVID virus that's out here, predominantly in this country, is very well matched to the vaccine that we're going to start giving.
There's a tendency for everyone to lump viruses all into one category. And to Andy's point, there are certain vaccines that have never changed, right? Because the evolution of those viruses it doesn't hapen. So I think the polio vaccine is the same as it ever was. Hep A is the same as it ever was. Hep B is the same as it ever was. So it's a reflection of the differences in viral life cycle that determines whether or not the vaccine needs to be altered or not.
Thank you.
I want to second a question that was placed in the chat for Arthur, because I was going to ask the same question, but somebody put it in the chat room. Which autoimmune diseases were you talking about that might have a problem with?
Now, this would be controversial. So the difference between traditional vaccines, say flu and pneumovax, is that these are proteins that have been made in the laboratory and injected as such. So they really are vaccines. Your body is making an immune response to the proteins. mRNA is the template from which live cells will make protein. So when you get an mRNA vaccine, it's taken up by your own cells, and your cells will make the vaccine. I don't know if that's clear or not, but the mRNA itself is not the vaccine. Okay, the mRNA is just a template from which the cells know how to make the real protein. mRNA is a kind of chemical to which a lot of people may react to. So one of the questions in the chat is, well, which diseases am I thinking about? Well, things more in line of lupus. There's always been a thought that maybe some viruses may be the trigger for lupus, and there's data dating back 30, 40 years. So in a sense, not all autoimmune are the same. All autoimmune conditions are the same, and they should be taken individually. But nonetheless, I do recommend my lupus patients to get the mRNA vaccine, and if they've had previous problems, then we talk about it. But it's more theoretical than anything else.
There's another follow-up question related to, I know Dr. Miller mentioned, and so did you, the annual flu vaccines and how that is part of our regular vaccine schedule. Somebody's asking, the flu shots yearly, although it seems that COVID has been more often. Will it become more like the flu, where it's just once a year? The vaccine.
I know. I'm gonna tell you honestly that I think so, but it's really not clear. Nobody's told me yet. And we'll have to, it's going to be very interesting this year to see what happens to COVID. Right now, we're having a mini spike in the city, but it's, hospitalizations went up a tiny bit. I certainly know a lot of people who got COVID in my community and around the hospital. Nobody got very sick. Is that going to be the way it is for the next 6 months, or is there going to be something else? Is COVID going to eventually evolve into a meaningless cold? We really don't know what's next. And I'm hopeful and I'm optimistic that it's not going to be a big deal. But, I look forward to talking to you next year about what we've learned over the last 365 days.
A lot of this goes into evolutionary theory, but the thing that distinguishes flu from other viruses is that it changes like clockwork. And so our vaccines come out like clockwork, as opposed to other viruses where, the evolution of the virus is a little bit more, I guess, fluid and unpredictable. It goes through, periods of stability and then sudden spikes, periods of stability and sudden. So I think, it's hard to extrapolate, and I'm curious also which direction it's going to go, but it's not the kind of clockwork timing that flu has.
Thank you. We want to get a little bit into scheduling, with the understanding that we'll be talking about RSV, we'll be talking about other viruses, and that's a larger question that people have about coordinating their schedule of vaccinate all of these different vaccinations together. But these questions have to do with when to plan the new monovalent vaccine after one's had COVID. What is the waiting time or the recommended waiting time? That's the first part of the question. And the second part of the question is, let's start there because the other one's slightly more complicated. How long should one wait after having COVID or having had the bivalent?
It's a great question. I'm just going to leave you with a simple answer, which I think is pretty good, which is 90 days, 3 months. Okay. Because you're very unlikely to get sick from COVID, or really even to get, you can get COVID again, but it's pretty unusual. And it's really unusual to get severe COVID within those 90 days. Afterwards, you're less protected. So that's a general guideline.
So whenever you get a vaccine or get infected, what happens is your body makes a sudden burst of antibodies. And these are substances that circulate in your body for long periods of time. At the same time, your body has evolved their white blood cells to be able to respond more quickly in the future. So vaccines actually do two things. It gives you an immediate burst, but also prepares your body for the future. And those antibodies that are made initially last about 3 months. And that's why that period of time, you're highly protected. And after that, the antibodies begin to wane. And so your immunity begins to wane as well. And so at that point, you want to bolster them up again. Is that fair, Andy?
Fair.
And then the second part of that question is how soon after having had your last COVID vaccine should you be planning your next monovalent?
I don't know. I guess there may be the person asking the question may have just recently gotten their bivalent vaccine. I think that waiting 3 months would be reasonable. I think that's about right. You're probably fairly protected for a while from getting COVID, but if you're planning to get the COVID shot anyhow, you'd wait at a minimum of 3 months.
Thank you. So here's the next question, and this I think is also something that people grapple with in thinking about when they're going to be vaccinated for this vaccination, but also for a number of the other ones that we will be talking about. What are the guidelines for getting vaccinating and pausing one's medications, biologics, disease-modifying medications?
I guess I'll take that one. A lot depends on, why you're getting the medication. So RA is a horrible disease, but most people can tolerate brief interruptions of their medication. So you're more apt to discontinue for the purposes of vaccination. There are other conditions that, where it could actually be life-threatening if you stop the medication, in which case you don't. What we're trying to do is optimize. It's never perfect. So for any given case, you want to make it as best as possible, taking all factors into consideration. Now, it also depends on which medicine is being used, because some medicines are perfectly fine to continue on, and you wouldn't have a diminished response to vaccination. And then the ACR is pretty clear on that. So not all immunosuppression is the same. I like to think of the immune system as an octopus with 8 different arms, and the 8 arms don't necessarily know what the other arms are doing. And some arms are more important for protection against this and other for that. So if you happen to be taking a medication that, that is targeted to the arm that is most protective for you, then that's a problem. That's a problem. That's one reason why rituximab, and I don't know if anyone on this call is on that medication, is the one that we're most concerned about because it has the longest half-life. It's around for 6 months. And it also targets the one arm of the octopus that you need to protect you from COVID. So even from the outset in 2020, where we're writing these guidelines, that was the one medicine that we were most concerned about and still are.
Are there any other concerns about any of the other medications that people with RA or inflammatory arthritis typically take?
Yeah, I mean, as I said, like things like methotrexate, which is the most common one, we try to stop for a couple of weeks. Most people with RA tolerate that fine. There are other medications like TNF inhibitors, which there's really not a whole lot of evidence that says that it's going to harm you to stay on it. So we tend to continue it. That's a little bit more controversial, but there's certain ones that are clearly we'd like to stop if we can. Others that we take on a case-to-case basis.
And definitely warrants a discussion with your rheumatologist before deciding to stop and plan your vaccine.
Right.
Somebody's asking about Stelara, which they take every 12 weeks.
Mm-hmm. That falls into one of those categories that probably it's fine to continue on.
Thank you. Next question. I know this is something I think we talked about last time, but I'm really interested, and so are some other people, of the updated answer. Previously, I had the Pfizer vaccine. Is it okay to take the Moderna and vice versa now?
Capital yes, it's fine. And there's no safety problem. and they work equivalently, and I don't want you to worry about it. And it's something we're asked about all the time, but they seem to be equivalent to each other and interchangeable.
Great. Thanks. We're going to move. There's also a question about, as I mentioned, timing, about coordinating vaccines for COVID, RSV, flu, all of these vaccines. But I want to first start talking about RSV, and then we'll circle back if that's okay. Does that seem like a good path? So the first question is, what is RSV? There's a lot of talk about it, and it's not a new virus, but it's definitely in the news, especially because there's now a vaccine for it.
Sure. So it's yet another virus, right? There are many viruses in the world, and several dozen that can infect human lungs and human noses and sinuses. And one of those is called respiratory syncytial virus, RSV. And when I was in medical school, and I'll bet Dr. Yee also, we were taught that it was primarily an illness of children. And really, because I'm not a pediatrician, I never worried about it. But it actually turns out that it does infect, logically, it certainly can get into adults' lungs and adults' airways and cause infections there. And only now are we really realizing, with better testing, actually, that it's a pretty decent cause of bad viral pneumonias and bad infections. So there had been multiple efforts in pediatrics to prevent this with vaccines and treat it with antivirals, and nothing worked great. But finally, they got an okay vaccine for RSV. But the adult, I almost said the human, the adult vaccine for RSV really seems to work well. There have been some studies that show that if you get it, your chance of getting RSV goes down by 90%. Is RSV as common as COVID was in 2000 and 2021? In 2020 and 20, it was not as common. But if you look at the reasons why people in an ICU with pneumonia are in an ICU, RSV is a nice slice of those people. So getting people who are prone to lung disease and severe outcomes to take this vaccine will likely decrease the number of deaths from RSV. So that's why it's recommended. It may lower your chances of getting a really severe pneumonia.
And that's a recombinant vaccine, so it won't have the mRNA complications.
Right.
So you spoke to the efficacy, which is pretty impressive. Do we have any information about safety profile for this vaccine in adults, and specifically in people with rheumatic illness or inflammatory arthritis?
Right. So I wanted to, thought about an introductory headline for my part of the talk, or what I wanted to say, I think here's my headline. The two vaccines you should prioritize this year are COVID and flu. And this one that we're talking about right now, RSV, I'm on the fence, and I'm not going to hit you over the head and tell you have to take it. It appears to be effective. It appears to be very safe. There are a couple of things hanging out there, some questions that we need more data about, and then we'll have that data in a year, hopefully. For instance, a question, sort of people are looking at whether it increases the incidence of some neurological diseases, neurological autoimmune diseases. Because they saw a couple of cases in one study, and so they need many more millions of people to take the vaccine until they're sure. And that is why the CDC has come out, and they have not said all patients above 60 should have this vaccine. They've said all patients above 60 should talk about it with their doctor. All right. So your doctor is going to talk about it with you, and some will know what they're talking about, and some will not. And some will have an opinion based on facts, and some will not. But there's a lot we don't know about it. Looks safe, looks effective, but we don't know all the facts.
Thank you. Do you have anything to add, Dr. Yee?
No, Andy's smart.
On that, I'm sure we all agree, as are you, Dr. Yee, and that's why
As
we
are
have
you.
a dynamic duo. So then let's talk about flu vaccine, since that's highly recommended. Can you share a little bit about this year's flu vaccine, how effective it is, how well matched it is?
I actually just checked right before this just to say, because I knew you'd ask that question. We won't be able to give you a number for how effective it is until after the season, right? That's at the end of the year they say, oh, it was 54% effective or 42% effective. But what I can tell you in the Northern Hemisphere, most of the time, the Northern Hemisphere ends up getting the Southern Hemisphere's flu viruses. And one season, 6 months before, because we're obviously separated by the equator. And this year's Southern Hemisphere flu viruses are an excellent fit to the vaccine that we're going to give. So people are predicting that it's going to be a very good year for the flu shot. I can't tell you more than that. We don't have those numbers yet, but it looks like the vaccine designers guessed right. And it is literally a bunch of scientists getting in a room and deciding what they're going to put in the flu vaccine based on some projections and some data, but really a human analysis of what is known about the viruses.
Thank you. Anything to add, Dr. Yee?
No.
Just the moral. He wants to say, get the flu shot. Be sure you get the flu shot.
I think that, so the flu shot, I think the thing, I agree with Andy's recommendations on the basis that there is a time sensitivity to some of this. Flu, I mean, this is the time to get it. And next year, it's not, it's going to be a different vaccine. Prevnar and RSV, for example, they're going to be the same next year. So, you have some time with that, and it's going to last a little bit longer. There's a question in the chat, Prevnar versus RSV. I'm not really sure what that question is trying to ask. They're two different vaccines addressing two different organisms, so they're separate. Prevnar is a vaccine against a bacteria known as pneumococcus, and it protects against 20 important strains, whereas RSV is a virus, so they're different. Yeah, I don't know if that answers Laurie's question.
Yeah. In terms of priority, then, just to underscore, you are, as well as Dr. Miller, recommending as priority the new COVID vaccine and the flu vaccine, and those are priority fairly soon.
And we give it together. I mean, it's safe to give together. That's pretty much shown to be the case.
Thank you. Anything to add?
Two things to add about flu, but I'll just ask. So one thing to add about the flu vaccine is, particularly for people above the age of 60 or 65, I don't remember the cutoff, you have the option of getting the higher dose flu shot. The higher dose flu shot comes with a sorer arm, and you may feel worse the next day, but it may work better. There's some data to suggest it works better. So if somebody says, we have both, which one do you want? I would personally opt that you get the higher dose one. If you are below that age, you're not a candidate for it. It's still a good question about whether patients with rheumatoid arthritis should get it, but there's very little studied about that question. But if you're in the older age group, you may have the option of getting the higher dose. However, if they don't give you the option and they say, hey, do you want the flu shot? Just get the flu shot, because any flu shot is better than no flu shot. Okay, so I want you to get one of them. A quick question, I guess, Arthur, you can ask. This was in the chat, but the question about how does Prevnar compare to the RSV vaccine could be interpreted also as, if you saw a patient with rheumatoid arthritis and they said, I'll take one of those two, which is more important for them to get on, tomorrow?
I would probably, well, if you haven't already gotten a pneumococcal vaccine, which a lot of people already have, I would probably prioritize the pneumonia.
Yeah, me too.
Yeah.
So I agree. So Prevnar protects against pneumococcal pneumonia. which is a major cause of horrible illness and death in the country. And it's one shot and you're done for life. So I vote for that if you haven't gotten that shot yet.
Since you're asking me a question, I'll ask you a question.
Okay.
In the past, so there are different flu shot preparations. There's standard, right? And then there's which is trivalent, right? There's quadrivalent, and there's high dose, right? So my understanding from the past is that the morbidity or mortality from either the high dose or the quadrivalent is the same. So they do just the different things, but they end up at the same point. Is that fair?
I have to update you.
Okay.
There are no more trivalent vaccines. There's no more trivalent vaccine. It's all quadrivalent, even the high dose one.
So they're equivalent. Yeah. So high dose or yeah.
Yeah. And it's interesting this year, one of the big excuses for people not giving the flu shot is allergy to eggs. They've done extensive research over whether that's something that's real or not. And plus the fact that true egg allergy with anaphylaxis is fairly rare. And it looks like it's not a big concern. So that whole recommendation went away. That's not to say you shouldn't be worried and you shouldn't be anxious and you should go to a good doctor to get their opinion, et cetera, of course. But it looks like all of that egg stuff was sort of overblown.
Thank you. Just to follow up, somebody's asking in terms of timing and priority as well. Somebody who's taken the flu and COVID vaccines already and was going to wait to take the RSV, but will be traveling to India. Should that person take it before they go to India, the RSV?
From his profile picture, it looks like he's below the age of 60. So if he's below the age of 60,
he is.
And then he doesn't qualify for that vaccine.
Okay.
I suppose the one thing that I would ask is there a lot of RSV in India?
That's another question.
I don't know. If there's a lot, then maybe it is something that you want to consider. I have no idea.
Marcia, your question is good. Marcia is asking, do they need to be taken every year? So the Prevnar definitely does not need to be taken every year. And the RSV, I think the jury is actually still out, but I don't think it's designed to be taken every year. But I can find out more about that. But Prevnar is once in a lifetime. Okay. In the past, the ones that you've gotten before were every 5 years. People were giving them different ways, but the newer versions are once in a lifetime.
Since they are once in a lifetime, I'm wondering, because there have been a few versions of vaccine for pneumonia. If you've lost track of your vaccination record and you're not sure whether you got Prevnar or you got the one prior to that, how does one proceed?
Yeah, well, that is something we see all the time. And usually what I do is I simply go ahead and give the next vaccine dose because it's safe.
So even if you duplicate.
Yeah, if you get Prevnar 20 this year, the new Prevnar, and then in 5 years you're not sure what you got and they give you another Prevnar 20, it's fine.
It's a booster.
Yep.
It's a booster.
There you go. I want to talk a little bit about Paxlovid. Is Paxlovid still effective against newer variants? Do we know that yet?
Of COVID.
Of COVID, sorry. Yeah. I'm switching gears. Thank you very
much. Paxlovid is the antiviral that's available against COVID. It takes, you take 3 pills at a time. You take those 3 pills twice a day. You take all of that for 5 days. And it remains effective against COVID. It is really the only antiviral that is easy to get as an outpatient that treats COVID. We have some inpatient treatments too. And it seems to keep people out of the hospital. So if you're somebody who has some comorbidities like rheumatoid arthritis, like lung disease, that may give you a higher risk of going to the hospital and you get COVID, it's smart to talk to your doctor and consider taking Paxlovid. You do need to be careful because it has some important interactions with other medicines. I won't list them here, but you need to be careful and talk to the pharmacy and make sure everyone knows what you're taking, because sometimes it's not a good idea, or you need to change some of the medicines you're on.
And some of the medicines are very common, like statins would be a very common one that interacts. Even steroids, that's another one, and anticoagulants like Eliquis. So there's a whole list out there.
Yeah. Which doesn't always mean you shouldn't take the Paxlovid. Sometimes it's worth taking it anyhow, but you need.
But you can stop the statin for a few days,
right,
and then you can have your dose of prednisone. So I mean, there are ways to play it, but do talk to your doctor about that.
Since we're speaking about medication interactions, anything to know about medications that people with rheumatoid arthritis or inflammatory arthritis typically?
No.
So we've breezed past a lot of the questions here that you've already touched on. So I'm going to go to some sort of odds and ends questions since we're talking about vaccinations. Polio, which has been in the news over the past 2 years. If you've already had a polio vaccine as a child, do you need another now? What are the recommendations currently?
Yeah, that was a really interesting moment, right? We had somebody in upstate New York who developed polio, and all of a sudden, a lot of infectious disease doctors had to go back to their textbooks and start reading again, because none of us have ever seen a case. At this point, no, you do not need a booster. If we decided that if there were patients, doctors, healthcare workers, people in the community of people who might get exposed to this virus, we would talk about getting the polio booster back into HSS. But it's not, fortunately, there haven't been more cases, but moreover, they haven't found the virus really anywhere in the New York City region anywhere. So I think for now we're safe. But, as our planet warms and people continue to travel the globe and people become more and more skeptical about vaccines in general, we will see what happens.
Yeah, that was a very bizarre case. If I recall correctly, it was someone who had contracted polio in Israel. It was the person was Orthodox and had not been vaccinated here. And so, it speaks to the benefit of vaccinating against polio. I'm going to put in the chat, actually. I'm glad whoever asked that question, I'm so thankful for it. There's a great book that won the Pulitzer Prize about 20 years ago about polio and vaccine development. An easy read. It speaks about polio specifically, but it has many different lessons about vaccines, and I think it's a great read. It talks about the politics of it, the sociology of it, and I'll put it in the chat.
Thank you. While we're talking about the chat, I know I just want to swing back because you had put something else in the chat having to do with holding medications for the COVID vaccination. So you mentioned that methotrexate may blunt the response to the vaccination, so you may not get the full benefit. Nonetheless, there will still be some clinical response, even if you need to stay on the methotrexate for your condition.
Right.
You could have said that, but I just read what you wrote. Just wanted to make sure that was captured here in case anybody missed it. So a few questions have come in, and we also really wanted to discuss, because I know there have been changes in recommendations in the shingles vaccination. And wondering if you can speak a little bit about whether it's live or killed virus, whether one needs to hold immunosuppressive medications, all of the new guidelines around shingles vaccination, which people are very interested in hearing about.
Well, the current form of shingles vaccine called Shingrix is a recombinant, and so it's completely safe and recommended. And I do recommend it to all my patients who are on immunosuppressives. I think the guidelines in terms of managing the anti-rheumatic illnesses are comparable to that you would give for other vaccines. The older vaccine is called Zostavax, which is a live viral vaccine, was a live viral vaccine, which no longer is available. But does bring home a very important point that you want to extrapolate to other vaccines that we still have that are live, like yellow fever. There are specific recommendations regarding management of antirheumatic disease among those vaccines. And the concern, valid or not, is that these are viruses that are still living but have been sort of dialed down a little bit. So in theory, can cause infection. And that's the case. Well, I don't want to confuse matters, but that's the concern. That having been said, there have been many cases of people who inadvertently receive live viral vaccines, having been on methotrexate or other medications of the like, and have not developed disease as a result. So it's really an abundance of caution, but there's actually not too many cases out there of real infection.
Thank you. Dr. Miller, do you want to add to that? Anything?
No, I think zoster is not something that will kill you. So
might make you want to kill yourself.
Well, that's exactly right. It's one of the, I've never had it, but from people who have had it, it can be just the worst and sometimes can be life altering because the pain sometimes doesn't go away. So really protecting yourself from it with these vaccines is important. And they actually don't necessarily prevent all shingles all that well. People still get shingles on this vaccine sometimes, but what it prevents is the really terrible cases where it changes your life. Yeah. So I think that everybody who qualifies should get this vaccine. It's, again, these vaccines are just so safe. And when something happens and it's picked up by the media, it gets amplified into this terrible disaster, and often they're disastrous. But what we don't hear about is the other 10 million people who didn't get that condition. So it's one of the most important vaccines to get, but this time not for a deadly disease.
And can you please clarify who is an appropriate candidate for this vaccine?
I think anyone over the age of 60, right? Is that the recommendation now?
Yeah, I'm just hedging because I don't remember if you're 35 and you have RA and you're immunocompromised. I don't think we give. I need to look it up. I apologize that I'm not sure. So you're going to ask you're going to remind your rheumatologist to look at the guidelines for if you're less than 60 and you haven't gotten the shot.
Well, for anybody, immunologically impaired or not, it's 60, and I think there is lower age.
Yeah, I think it is a lower age because some of it's indicated for younger people because one of the issues is what do you do in somebody who's quite young, let's say with rheumatoid arthritis on some powerful immunomodulators who got the chickenpox vaccine when they were a kid just 10 years ago and now, or 20 years ago, and now it's time. And so there are new infectious disease and vaccine questions about these types of patients that we didn't have before.
We should clarify, Andy, that shingles is actually a reactivation of a virus that's already in your body. So what happens is that when I'm of the age, I got chickenpox when I was a child. The virus hides in my body and is still there. And so under certain circumstances, such as immunosuppression, it will come out, but it will follow the pathway of a nerve. And that's why it's always like this band-like rash on one side of the body. And because it follows a nerve, it can irritate the nerve. And even after the rash is gone, you have the pain because the nerve has been irritated. So if you're at risk if you've had chickenpox before in the past.
And I will clarify because I don't like getting things wrong or half answering them. If you're above the age of 50 with any medical problems or no medical problems, 50, you should get 50. It. And if you're above the age of 19 with immunocompromise, you should get it. So I'll bet that many of the people on this call should get it if they haven't yet. And we're talking about Shingrix for shingles.
Thank you. You mentioned, and so I want to just follow up with a question. You mentioned the circumstances around somebody receiving the chickenpox vaccine and then later on getting shingles. And do you have anything that you want to add about that? Because there are people in this room who are in their 20s who would fall into that category.
So it looked that's how I knew that I'd answered incorrectly before. But recommending that those people get the Shingrix vaccine, even though their risk of getting shingles is actually quite low. And the risk of getting shingles is quite low because they may not have the varicella virus in their body because they got the vaccine when they were a kid. They didn't get chickenpox. That said, if they do get shingles, it can be severe. And if they get new chickenpox for some reason, that's very severe in somebody who's an adult with immunocompromise. So having a vaccine against this virus is still thought to be important, and you should get the Shingrix shot.
Thank you. Somebody's asking if the shingles vaccine is only once in a lifetime or a series, one and then another in 6 months.
Yeah, so it's you get one and then another in 6 months, and that is supposed to be good for life. I'll mention if somebody on this call is 25 and they get these two shots, and then they pass let's say the age of 50, 25 years later, should they get a booster? I don't think modern medicine has answered that question yet. So it's very possible that they should get a booster. We just don't know.
Thank you. I want to give you both an opportunity to share some pearls of wisdom and takeaways from this discussion, top recommendations, and just how you want to frame this discussion before we leave.
I think one of the most confusing things for patients and doctors alike is this constant, I guess, change in directions every now and then in terms of recommendations, and it makes it seem as if the medical community doesn't know what it's doing. In fact, we are very carefully watching developments to see if there's signals that we have to pick up on to alter the way we do things. And I think that's what science is. So if people are out there frustrated because they're not getting the answers that are more definitive, it's basically those answers are being worked out. And sometimes the answers are just slower to come. But we've come a long way. I mean, as COVID, I mean, you think about where we started from like one case in Seattle to identifying the virus and then coming up with a vaccine and remedies within a year. I mean, it's remarkable if you compare that to the polio experience, and that's why I pointed people out to that, just to understand that this constantly evolves. And so I just want people to bear that in mind.
Yeah. The things we're talking about today are actually pretty complicated. They're detailed. And I'd say many, many doctors know less than you guys, based on the questions you're asking about the nuances of them. Every time, you say, oh, but there are so many types of COVID vaccines, or, which Prevnar which pneumococcal vaccine should I get? It's largely because each one is an iteration of the last one and an improvement on the last one. And so some of the vaccines we've got right now are much better than they were before. Certainly Shingrix is much better and much safer than Zostavax was. And Prevnar is much better than Pneumovax was. We know that we end up knowing the history of these as you go on in a career in medicine or as a patient. And you just see how these things change.
Thank you so much for being here and taking the time to answer these questions so thoughtfully and authentically. And thank you, Dr. Yee, also with a very full plate, sharing your time and expertise as well. We're going to close here, and people are saying, please feel better soon, Dr. Miller.
Thank you. I feel good. All right, Dr. Yee, a pleasure.
Feel better, Andy. I'll see you.
Pleasure. Thank you so much.
Bye-bye.
All right.
Thank you.
Dr. Miller, Dr. Yee.
Bye-bye.
Bye.